Good evening, everyone, and welcome to our third webinar in the Better Billing webinar series, Care Plans and Chronic Disease, the MBS update. And this is our last webinar event for the year. My name's Helene. I'm the Workforce Development Officer at Westwick PHN. Alongside me is Jade, who also is in the Workforce Development team. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country today. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. You'll see that link. You'll have access to that link in the chat. Tomorrow and Thursday evening is our last education dinners for GP and practice managers for the year in Ocean Grove and Hamilton. You can enjoy complimentary canopies and sit-down dinner with your colleagues. The registration link's in the chat. It's not too late to register for those events. Please make note of that Westwick Health Pathways relating to this topic that's on the screen at the moment. This is a free online resource with localised clinical and referral information for health practitioners. You'll see the slide there and some of the related pathways available. Westwick PHN will provide a certificate of attendance. So if you could take a moment to check that your full name is displayed accurately on your screen. If not, or you're unsure, just please rename yourself or type your first and last name in the chat box. This way we will ensure we can issue you with a certificate of attendance. The event is being recorded, so please keep yourself on mute unless you would like to ask a question during the designated question and answer time, and this will be at the end of the formal presentation. We encourage interactivity and discussion, so please feel free to type the questions in the chat box at any time, and I will ask them on your behalf to the presenters at the end. Your feedback is also important, so if you could take the time to complete the event survey after the webinar, there'll be a link in the chat box to that. So this evening, our presenter is Ash van Leeuwestyn from Better Billing. I will hand straight over to Ash to start the presentation. Thanks, Ash.
Thanks, Helene. Okay, so hopefully everybody can see my screen. This is our last one for the year with Better Billing, which is good for us all. Means end of year is coming, a bit of a rest, hopefully for some of us. And this one is probably the most popular topic that people consult and talk to me about most often, and that is the care plans. And obviously this is a changing space at the moment because we know that there's a lot going on in terms of Medicare and what Medicare might be doing with us in the next 6 months. We're not particularly sure, but slowly and surely it will come to light. But this is about the most current guidelines. So this is what you can do starting tomorrow in your practice if there's anything you learn from this today. So in terms of the agenda of what I'm covering today, so I really kind of simplify what the MBS is sort of saying around care plans and really frequent asked questions. So questions that I often get asked and I hopefully give you a bit of an answer before you need to type them or ask. I also am a lover of templates in so many ways, and I've got a QR code for you guys to all scan or jump online and get access to those for me. So we'll go through that. SMART goals are a really good way to focus on making really good goals for your patients, and we'll go through them. I have a bit of a system I use. Of course, co-billing, which is what everybody wants to talk about, and then the future of care plans. So what do we know so far, which is just a little slide at the end. So anyone who's been to my webinar so far knows that I love using examples of patients who I've just made up. But we can all kind of think, yes, I know exactly who that patient is that she's talking about. So let's start with this one. And I want you to just reflect on how this is set out. If anything you take from tonight, it's the way that I have set this out as to the best way that you can, or one of the best ways that you can optimize chronic disease management for your patients, and how I look at doing it. So we've all got a patient that's named Barry who's probably 78 and who has probably got diabetes, blood hypertension, and hyperlipidemia. So he's that perfect metabolic picture. And Barry sees you for the first time, or has been seeing you for years. And yes, he definitely qualifies for a care plan, and we'll go into that. So you can see here on the side, I've got two different columns. So there's the side that has been optimized, and then there's the side that you don't optimize, and you just sort of bill a 23 every time you see Barry. So say for instance, you're seeing Barry 5 times in a year. And in this first one, for the sake of this example, we'll say you've seen Barry many times before and you are his regular GP. So you do your care plan, and you do your team care arrangement. And then you end up seeing him 3 months later, and you've got your review option and also co-billing the health assessment. So we'll get into that of the co-billing, but remember that these are options available. 10997 is a code that you're able to use when somebody has a care plan and they're reviewing their goals with your nurse, or they're doing activities to help with with their goal setting. Then I see Barry again 3 more months later. He's due to come in just for whatever that he might be checking. He might be getting prescriptions. He might be getting repeat blood, seeing how his diabetes control is looking, or we want to check his BP. And at this point, I've also set him up with my pharmacist, who's gone and done a lovely medication review. So again, we've done a 732. My nurse has done it with some chatting about goals, talking about this blood pressure. How's your diet going? Are we following that healthy heart, or are we back to eating fish and chips? What is it? Then also reviewing his medication review here. So you can also bill a 900 in this case. Then he comes and sees you because he's ended up with a lower respiratory tract infection, and he's out of the loop of the reviews. But in this particular case, you see him for a private consult, and you also get him in to see the nurse at the same time, because in this case, he might have been smoking and we were trying to get him to stop smoking, and your nurse gives him a bit of an idea on how to use the patches. Then for the 5th time in the year, which is his third plan review, which is your 732s, he gets his review with the nurse, and the nurse also does an ABI, because Barry is absolutely someone who would benefit from having an ABI. And the biggest thing to take from this is the cost to Barry and the fees to you. And I would say 90% of my patient load is set up exactly like Barry. So they see me generally in this particular order. It cost Barry $80 at one time that he's seen you for his lower respiratory tract infection. And in terms of billings, is approximately about $1,300. In the case of Barry not having anything set up, not setting up your care plans, not thinking about reviews, not thinking about health assessments, chronic disease items like your medication reviews, you end up with 400, and Barry does put 400 on the table, and obviously will get his rebate as well. So if anything, think about this, take a screenshot, whatever you want to do, take this back to your practice and say, how can we set this up? How can I prepare my patients for this? You'll see a substantial difference, obviously, in terms of fees, but also look at how many more things that Barry's been able to access with the nurse, pharmacist, an ABI, and these haven't come up as any particular cost to him. So with that, let's get into the actual nitty-gritty of it. So 721 is your GPMP, 723 is your TCA, and 732 is your care plan review. So I will try to be as slow as possible with this and try and I will interchange the terms, but that is what I'm talking about tonight. So in terms of who is eligible for these conditions, for these numbers, my apologies, is chronic disease patients with a condition that will outlast 6 months, or that they are now terminal. The patient has to be in the community. Private inpatients at a hospital being discharged are also okay. Who cannot have this would be your care recipients at the RECF. So those patients access a 731 number, or if they're currently an inpatient at the hospital. It's no dice. In terms of your frequency, your care plans can be done every 12 months. Your reviews, including your RECF reviews, can also be done every 3 months. So this is having a look at the MBS. When you go and in there, it's got, you put in 721 into search, it's got this huge wall of text. And these are the things that I will explain to people about care plans and their reviews, is what needs to be in the care plan and what actions need to be taken by you. So what is the minimum that you need to have in the care plan, and what is the minimum things you need to have in your notes and also do with the patient. So as we get to the templates, I really recommend that you register and say, yes, I'm happy for me to send you some templates, because I have a lot of things that I put into notes just as an autofill that I've discussed the care plan with the patient. And that is mostly to tick the boxes for Medicare, because that is what we need to do. So in terms of the care plan, on the left-hand side, this is what it needs to be inside of the care plan. So your patient's healthcare needs. So what is it that they actually need? So let's say, for instance, with Barry, he's type 2 diabetic and he's really poorly controlled. He's shocking at checking his sugars. And so at the moment, his healthcare needs that we need to focus on is improving his diabetes and his ability to manage it himself. History and relevant conditions need to be in there. So now normally I will have that just filled. My template will have a fill in of all of the medical conditions that I have seen Barry for. So his hypertension, his hyperlipidemia, his previous pneumonia, etc., which is auto-filled into there. Actions by the patient. So really, really important that we actually put things in there that the patient has to do. If you're finding that you're writing a care plan and you've got no actions for your patients, what is the point of this? So in this particular case with Barry, as an example, we're going to say that Barry needs to start to at least check his sugars for me once per day, or he needs to come and have his regular blood tests every 3, 6, 9, 12 months, whatever it might be. That is his job. Okay. The treatment and services needed. So this doesn't mean a TCA. This isn't a care. This isn't a team care provider component. But what is it that Barry actually needs? Does he need help in terms of diabetes education? Is he having really bad, is he not moving well and needs exercise physiology? Is he need a dietitian? So these are the things that we identified. This is what Barry actually really does need. How are you arranging these services or treatments? And when you plan to review. So this is a really commonly missed one, is when do you plan to review? Now, BP, if for those of us using best practice, will automatically say, I want to review this plan in 6 months. You can change that over. For me, it is always 3, because I like to have the reviews in, having everything sort of timed in a way that when I end up seeing them every, 3 months, it falls on a care plan review time, which is good for both of us. And then what actions need to be taken. And Medicare says you've got to consent your patient or the patient's carer. You've got to record the plan and record that the patient agrees. Now, there is a lot of templates that print out and make the patient sign them. You don't need to have the patient sign them. You can have verbal consent. It needs to say that there is consent. The patient has agreed. We're all happy to go ahead. So if you're wasting, a forest of trees every time you do care plans, rethink it. You don't have to do this. Offer the plan copy to the patient. I mean, I've probably got a handful of patients that I can think of that actually take the plan, but it's a point that you need to mention that you've offered it. And then you need to retain the plan for 2 years, which all of our software is going to be doing that anyway. Now, 723 is your team care arrangement, and this is you plus 2. And we'll get to what I mean by you plus 2 and the care providers in the frequently asked questions. They come up a lot. But what actually needs to be in the team care arrangement is goals. Okay, so there needs to be actual goals, and these are created by yourself, your nurse, your patient who's come in and said, I want to say, for instance, I want my sugars to be under 10 in the morning, whatever it might be. And so that's their goal. We'll go through how we create goals in a second as well. Then the treatments and services from each provider. So in here, you need to be really specific about, I would like the diabetes educator to help Barry learn to use his continuous glucose monitor, to focus on home testing when he's symptomatic and what that looks like. Or I would like Barry to see my dietitian to help with help with better food choices, learning about carbohydrates and different types. Actions by the patient. Again, what is Barry doing? And then when you plan to review also needs to be in the team care arrangement. In terms of actions, very similar to what the care plan, the GPMP it also said, so consent and explaining the process, explaining the patient to their providers and their roles. So a diabetes educator does the following. A pharmacist for your medication review does this, and explaining that in your notes that you've actually done that is a big part of it too. And record your agreement of the patient. The patient is happy to proceed. They understand there may be a charge with the allied health professionals, whatever that may be. And again, retain your plan for 2 years and offer a copy. So again, in the software, totally fine, and mention that you've offered a copy. And then your 732. So this is your reviewing, and we'll go through this bit a little bit more slower as well. But in terms of reviewing the GPMP, so that is one of the 732. So for anybody who is unsure, if you review a GPMP, that's one of the 732s, and you review a TCA or a team care arrangement, that's a second 732 that you can bill. And there's a few differences between the two as to what fulfills your ability to do that code. And I'll just go through that now. So the biggest thing, again, the consent, explaining the process and say, hey, I'm going to review that paperwork that we did about 3 months ago where we said, hey, Barry, I want my sugars to be under 10 in the morning. And you say, hey, how has that actually gone? And Barry says, oh, I've been really bad. I'd say they're 18 now. They've gotten worse. And you think, okay, all right, so the goal is definitely not reached. Or maybe we need to alter the goal. So is our plan now that Barry gets it under 15? Is our plan that Barry now gets it under 12? Whatever that might be. And what our plans might change. So that might be changing his management, increasing his insulin, whatever that might be. And then again, same thing, offer a copy and retain the plan for 2 years. The team care arrangement, so this is, again, consent. What you have to do for claiming a TCA is you have to have consulted with at least 2 of the providers. Now, for some of us who might be in really nice big super centers, we've got our physio downstairs and our pharmacist is next door, and we've got our podiatrist there and whoever we might need to see. You can your consult can be popping your head in and having a chat. Hey, I just want to see how you've gone with Barry. Did he end up coming to see you? How did it go? Or that might be getting a letter back saying, hi, I have had my first visit with Barry. We're going to catch up every month and talk about carb counting. Great. There needs to be some evidence before you can review this TCA. Quite often people will argue, yeah, but the point of the TCA is to check that they did the thing that they were going to do and then they didn't. And so therefore I should be able to bill it. And I agree with you 100%, but it's just not what Medicare says. So then in your TCA review, you're in that 732, you also need to write if there's been any amendments to the services required. So say, for instance, Barry's gone, I don't really particularly like that diabetes educator, or I think I'd actually rather go to the one my friend goes to down the road. Okay, no problem. Whatever amendments that might be. Again, retaining the copy of the plan and offering them a copy as well. So frequently asked questions that I'm often asked is, my patient needs a new care plan. Can I do it earlier? Okay. Yes, under exceptional circumstances. So if things clinically change for that patient and in an urgent and a way that, so let me try it in terms of examples. So if the patient was previously Barry and then Barry all of a sudden comes to me and now has small cell lung cancer, that's changed. That's a completely different circumstance. And all of a sudden what we need to do is focus on changing the goals of that care plan to comfort care, palliative care, psychology, whatever that might be. Those are significant circumstances. If Barry has his diabetes just gets worse and his HbA1c is 10% now, and his morning sugars have been 22 a few times, it's still the same condition. It's not exceptional circumstance. There's no significant change in clinical conditions. There's no new care requirements. He just needs to be better at what we were already planning on doing. Who can complete and bill a care plan? So the usual GP is who the GP has seen for the last 12 months or will be seeing for the next 12 months. So for anyone moving to new locations and they said, no, I'm going to move all my stuff to you, I want to see you, and that's their plan, then you are in all right able to bill that care plan. In terms of moving to a new location and saying, can I bill another care plan because the new circumstances is that they've moved states? Not particularly is the answer. So you need to focus on their clinical condition rather than the fact that they've moved geographically. What can I bill at the same time? That's coming up. So that's always a common question. And do I need a signature from providers to bill the 723? So if anyone's a bit of a lover of the MBS like myself, you would have seen that there's been some changes to the 723 writing. I noticed it in about October, where previously it used to say you have to have a signature or you have to have consent received from your provider before you bill your TCA, your 723. That has since gone. Okay, so previously, yes, but the most recent look at the MBS, and I checked this again yesterday just before I came on because I thought I don't want to mess this one up, has got nothing about obtaining consent from providers prior to billing. I say proceed with caution. This is information for you to process and choose yourself. What will I do in practice at the moment? Probably the same thing I've been doing already, which is getting my providers to sign. I use very great responsive providers who give me a signature within 12 to 24 hours. So I'm not really concerned from that. If you don't have those providers and you have the ability to choose other ones, I really recommend that you get in contact with your core people. That process will improve dramatically for you. Why has this changed? I think this is about preparing us for July 2025 and those changes that are coming there. So have a look yourself, go through it, and think about in terms of your 723, if your providers are not coming back, it's changed in the MBS, but proceed cautiously. So templates, how do you do it? What do you do it? So this is an absolutely terrible screenshot of BP on the left-hand side. And then there is your care plans that we've all got some templates that are probably donkey's years old in our letter writers, where someone's written all of the, this is what they should be doing, 30 minutes of walking per day, or this sort of exercise, complete cessation of smoking. So these care plans, it doesn't matter how you do them. Either one of them are completely fine. But the way that you write the goals are the underpinning of your care plans. Okay, so if this was to be audited, the goals are likely going to be what will trip you up and have you paying it back. So which we'll focus on coming up. I personally use the template in best practice, which is under the chronic care tab on the left-hand side. And it's just, I have a lot of the similar tasks that I like to see for my nursing staff to do. And as a result, this is how I like to do it. Will it change in July for me? I do think so. For those who have been to my webinars already know I love AI and I'm a particular user of Lyrebird. And I have got Lyrebird being able to make care plans based off my discussions now with my patients. So these are things to look at. Whatever I say in terms of templates, just find what works for you and stick with it and really hone it in and make it perfect, because the quicker and the easier it is for you to do a care plan, because all doctors should be able to do their own care plan. It should not be at the whim of the nurse. It's your care plan and it's yours to be made perfect. So, what is a good and a bad care plan? In part of my role in better billing, which if anyone is interested in and they want to talk about it with me further, they're more than welcome to, is I audit care plans. So I quite enjoy doing this, and this is finding good and bad care plans. And this is what I would call a good one on the left-hand side. And the goal format is in a smart format. It doesn't have to be exactly smart, but I just quite like it because I feel like I can remember what each of the letters mean. A goal number, one or more. You do not need to have 10 goals, 5 goals, 2 goals, whatever. One or more is plenty. For me particularly, I like to do no more than 2 for my patients because I want them to be actually possible to reach this goal in a year. or however long. Tasks, so when you pop the little tasks in the BP pop-up box or in the document that you have, you can have as many tasks as you want. The tasks are irrelevant. They're not a part of what needs to be in your care plan. As the focus, they can be written as check BP, 1/12 as a monthly, or they can be Barry must come into the surgery and see the nurse once a month for them to do their blood pressure, for them to do his blood pressure, however it likes, however many you want. Care providers, so TCA, it's you plus two, and no, you do not need a specialist. So this comes up quite a lot. I'm unsure where this came from, but you do not need to have a patient, does not need to see a specialist for you to bill a TCA and process the TCA. So say, for instance, Barry and his diabetes. Barry doesn't have an endocrinologist, but that's fine. He still is able to access as many of the care providers that I'm able to give him in the TCA. Okay. If he does have it, then that can account for the U and two. So say for Barry's case, he might have myself, an endocrinologist, and he might have his diabetes educator, and that's three, and that's perfectly fine. But if not, I could have the diabetes educator and a podiatrist for Barry and myself, and that again is three. Family members, carers can be included in the team, but they don't count for three. Okay. So bad one. What does a bad care plan look like? One word goals: lose weight, or one sentence goals: lose weight, better sugar control, normotensive. They're not goals. They're not goals. And this is what happens with a lot of the poor care plans that get picked up. Okay. Goal number. There's no goals, or there's just no goals in there, and it's all just like, LDL under 1.2, BP under 120. Then they're not really goals, and therefore there's no actual one specific goal. Tasks. So there's no task. There's nothing in there for Barry to do. There's none in there for you to do. It's just got none. So it's pretty much empty. So anyone who's just doing the template and says lose weight, you're in serious trouble. Care providers, obviously, in bad one. That's not what I've kind of gone through here. So SMART goals. So this is a template I use. I have this up in for my nurses in their treatment rooms or their clinic rooms for them to help me create goals. So if I get them to see a patient for my care plan, I normally will pre-write the goal in there for them, because that's my responsibility to make sure that the goals are perfect, not theirs. But if they can make some for me when I haven't been able to, it's amazing. And so this is the SMART is, not a new format that we haven't heard before. All of us would have heard of it before. So the first bit of the goal is it needs to be really specific for the patient. So I have two particular examples. So in this case, what we'll do is focus on Mark. So Mark wants to reduce his blood pressure medications down from 3 to 2. So that's what he really wants. He's sick of taking 3 tablets. He wants to take 2. Okay, no worries. So how is this measurable? So the goal needs to be measured. And so in Mark's case, it'll be his blood pressure. And he needs to have it checked every 3 months. That's our plan. Then the A component is achievable. Can the patient actually realistically do this? Could Mark realistically drop down one of his hypertensive agents, or does he sit at, a systolic of 190 and we think, oh my gosh, we're all just holding it together? Or is it actually truly possible? So relevant. So does this actually make any change to their health? So in this case, if Mark could reduce his pill burden, that's great. But also it's helping him his overall health in terms of his blood pressure and making sure that it's reducing, and he's doing good things in order to be able to do that. And timeline. So Mark will assess the removal of one of his medications in 12 months. So we decide that this is what we're going to do. And in terms of Mark, he needs to come in, get his blood pressure checked. His other tasks might include, focusing on weight loss, might be focusing on other sorts of things like exercise, reduction in, fatty foods, whatever it might be for Mark. And our plan is to see that happen within 12 months. And yeah, so putting it all together, this is what at the bottom is what my goals actually do look like in my care plans. Is that Jan will lose, so in this camp, it's Jan, so I have a read of hers, but Jan will lose 7 kilos before seeing her daughter in America in 6 months' time. Jan will weigh herself on the first of every month for the next 6 months. And she's hoping this will actually improve her diabetes because she's also diabetic. So this is a foolproof goal. There is no budging as to this is not copied and paste. This is so specific in so many ways. We're clearly putting out how we're measuring it, and we know exactly when we want to do this. And it's achievable. She could do 7 kilos in 6 months. So this, have a look at it. You're very welcome to, take this, use it yourself in your clinic, whatever you'd like. Documentation. So this is the part where I mention about the documentation. So I have templates for notes, AI scribes, templates in particular, Lyrebird, and templates for my actual care plan, which I create in that BP software, and then I actually copy and paste into a letter writer and send it off to my providers in one fell swoop. So you're very welcome to access those. If you go ahead and log in or just register your information, your email in there, I will send it out to you because there's a lot of it, and for you to access it through here tonight would be a lot. So that way I'm able to send it all off to you in the next few days. So if you haven't, I will go back to this at the end so you'll be able to scan it, but just try and jump on and register for that, and I will send them off to you. Okay, my co-billing. So these are my co-billing buckets. So these are the buckets that I tend to use when I try and explain to people that, yes, that is a co-billing option, and no, this isn't a co-billing option. And in these ones, we've got our good and our bad buckets. So naturally, your green buckets are your good to go, and your red buckets are your not good to go. So in this case, this is about care plans, and this is about billing a 721 and a 723, and in this case also the review number 2. So we'll go through each of these item numbers to see where they sit. So in terms of the first one is a mental health care plan. Yes, you absolutely can co-bill a mental health care plan with a GPMP and a TCA. So I get a lot of questions saying, is depression something that we can create a care plan for? I mean, absolutely. So if your patient it's been suffering with clinical depression, it's been going on for well more than 6 months, which is diagnostic anyway, and you think that actually do really well in terms of accessing more psychology or accessing an exercise physiologist, or there's a social worker, or however you want to use the TCA, this is absolutely viable option. I would say in this particular case, if the depression is a short-lived episode, requires only a mental health care plan, and there's no use for other people being involved, there's nothing else that your patient can be doing other than accessing therapy through a mental health care plan, I would say proceed with caution. It's unlikely then for you to be able to say, yes, there is relevance for this, but in a lot of cases, our patients with mental health issues have a lot of other health issues going on at the same time. So please feel free that you can access it. 23, 36, 44, classic consultation. No, you cannot. So there is one exception, as always, is extenuating circumstances, urgent and concerning, and you need to acutely see something. And quite often what will happen in these cases is the patient will come back and they've had a fall and all of a sudden their head is split open, or they've hurt their knee, or they're bleeding and they just need to be assessed, or an ambulance is called. And these are those situations. Document ferociously, and really make sure that you can see that it actually is an emergency and relevant. But however, as a general rule, it's a no. Health assessments are going in the green bucket. So health assessments absolutely can be done and co-billed on the exact same day as your care plans. And quite often I will do the same. So in particular with reviews, I will definitely do it. I'll get them to see my nurse, say, for instance, if they qualify for a 715 or a 705, whatever it might be, that they'll get their health assessment done on one of the days I might do a review. I will quite often do that. You can theoretically do it with the care plan yourself. When you think about it, that might be a bit of a burden on the nurse and yourself, but if you can do it, you can. I definitely can do it. I will often get my nursing staff to help me with the health assessment, and I have been able to do my care plans quite quickly and within the consult. So if you set things up, it's definitely possible. Sexual health, telehealth item numbers. Absolutely. So, mental health, no, GPMPs, TCAs, and your reviews are all able to be done via video and telehealth. So, if you have telehealth in your practice and you haven't used it yet, please try. There's some really good access numbers with telehealth, and one of those is the sexual health item numbers. So being able to say and discuss something that's irrelevant for the care plan. So say, for instance, I might have a patient who is has osteoporosis, and then all of a sudden I'll check in on her cervical screening and or menopause or those sorts of things that are separated from the care plan. So you can absolutely do them at the same time. So the COVID vaccine numbers absolutely sits in the green bucket. You can bill these numbers with pretty much anything. So that's 93644 for those who are looking for what that number is. And that is discussing around whether the COVID vaccine is something that they're interested in, if they're where they're up to, educating on the COVID vaccine. The patient does not have to take up the vaccine with you to bill that number. It's able to be billed unlimited amount of times, and you only have to have stock in the fridge. So if you do not have stock on hand, you cannot bill this number. So the flu vaccine, where does this go? Nope, in the red bucket, because there's no number for the flu vaccine. It's a 23 or 3 generally, and you can't really co-bill this with your care plan. Okay. So mental health care plan review, absolutely in the green bucket. So quite often if I have patients with a mental health care plan and a GPMP and a TCA, I will do 3 reviews in one hit and review each of those things. They're all not time limited, which is amazing, and able to really access where they're at with things. So you absolutely can do that at the same time. Then the 2713, which is your mental health care consult. And that is like a normal consultation general attendance item and is treated similarly. So it's got the 20 minutes minimum. And it also cannot be co-billed with your GPMP and TCA. Okay. So in terms of those in the buckets, that is how I would look at it. So if you want to screenshot it or have a look at this at any point in the video, this would be the part where you go, this is what I can and can't do. So then I get always asked, Ash, how do you set this up? And that's pretty much exactly like I have done with Barry. So say, for instance, I identify a patient who can receive a care plan. And in this particular case, I might see them for the first time. I might see them for a few times and think, oh, normally, for me, I would say it's the first time and I've already identified them because I have a process of seeing how I can best access chronic disease for each patient that I'm seeing, if they're even relevant for them. Then I will organize a recall appointment or a follow-up. So that might be bloods, there might be a checking in, then we might have only got through half of the problems, whatever it might be, there'll be some sort of recall generally with these patients that I want to see. And when I'm at that recall point or a follow-up, I'll normally mention to my reception staff that I want nursing staff initiated in a pre-consult activity. So for me, I think about, okay, is this a care plan situation? So a 721, 723, is it a 699 situation? So with a heart health assessment, could there be an ABI involved? Is there another health assessment or something that I'm involved with that I could have my nursing staff help me with before they see me at my follow-up? Quite often I explain to the patient that for you to have a recall with me, and how I like to do it is you'll see the nurse for half an hour, 45 minutes before you see me. If you do this, the appointment will be bulk billed, and quite often I've got really good return rates with that exact same. Then they'll see me in the consult, and what I might do in that consult is send off the co-consent form. So I'll check that my care plan looks good and it's going to my providers. I'll check the goals and make sure that they're SMART approved and they seem right. So in this particular case, I might focus on interventions or whatever we were going to follow up, the results, etc., and document in the notes the creation of the care plan for myself, and then the care plan review, which I'll say I want to see you in 3 months, or I want to see how we're going in 3 months, and then I'll bill the TCA when it returns. And this is normally how I process every patient that I will see. They will be on this schedule. It's all about just thinking about it. So however you like to prompt yourself, I recommend finding a way for yourself to do it. For me, a plug for Doctors Control Panel. I don't have any affiliation with them. Full paid subscriber. Absolutely love that. I love it. Initially, I was not too convinced, but it's a game changer. So if anything, have a look at what Doctor's Control Panel does. It's a nice little screen that I have in the corner there, and it pops up nice and red and says, "Hey Ash, you haven't got a care plan for this person. What are you doing? They qualify. They've got chronic conditions, or a mental health care plan, or they're over 75 and they should be having their health assessment." And it's a really nice tool to be able to help yourself look at what that is. Okay, so shameless plug for them, Doctor's Control Panel. So this is my final slide of the evening. So this is about what does the future look like in July 2025. We thought it was coming in November, and it obviously didn't. And what we know so far, and this is directly from the MBS, is that the current GP management plan and team care arrangement items are being replaced with a single GP chronic condition management plan. TCAs are gone, and we have this new GP management plan. It's similar patient eligibility, again, so it has to be your regular patient, can't be in a hospital, not for an RACF patient, allows for ongoing MDT care. So it really removes the paperwork component of the TCA and allows you to just send a baseline referral and say, this is what I'm wanting for my patient. I'm going to refer you for diabetes education, whatever it might be. There's no more U and +2. So the fact that you need to have two providers for this patient is gone as per Medicare. So, and it is up to the discretion of the GP that this is a chronic condition, and as a result end up needing to have a chronic condition management plan. It is also been told that there's the same fees for both the GPMP, so the actual management plan, and a review. So really, really encourages the use of reviews. Reviews are so underdone. People often don't do it and just kind of come around and wait every year and go, oh, here we go, it's time to repeat it again. And I really encourage you to use your reviews for yourself and your patient. It's a really, really good way to see that they're on track, and it gives you a little bit of breathing space to have a look at the bigger picture sometimes. So hopefully, I was just chatting with Helene and Jade before this. I will be doing more webinars with you guys in around July, when we know a little bit more, and getting everyone a little bit more prepared and seeing what that looks like in practice. So hopefully, we will be able to sort of meet back up at that point. What I will do is take any questions. I'll leave that QR code there on for anyone who wants to scan in and have a bit of a pop their email down so that I can send them information about the templates, which will be out in the next few days. So in order for you guys to choose whatever you'd like to get from it. So I hope that was helpful, but let's see how the questions have gone.
Thanks, Ash. Starting with the questions, removal of lesion question mark. Can it be co-billed on same day as timed visit?
As time visit in terms of care plan? Let me just have a look. Has it been written up there?
Yeah, I think it means it's the timed visit that they actually go in.
Let me see where they've got that. Removal of lesion, can it be co-billed on the same day as a timed visit? If it's separate, if they're completely separate, then yes, because that removal of lesion has come from a previous consult, which you've held the billing. I would say yes. It's not really care plan related, so I'm not going to get too into it. But in this particular case, I would say that yes, it can, as long as it was done as two separate things. So they came in 2 weeks ago, your lesions come back from pathology, and then you've got a completely new topic that you've discussed with them at the time visit.
Okay, what about 10997 plus 10991 for Fluvax with 732 plus 732 when seeing nurse if
Yeah.
COPD?
Yeah, absolutely. Absolutely. I love it. Yes, absolutely. So when I would do reviews and my nursing staff are involved and they're all of a sudden giving a Prolia injection, then absolutely you can access the 10997 number. I really encourage the use of that. I know there was the push against using that when we're all getting letters saying you're all using it wrong. However, these are the reasons that your nursing staff are involved, and that is a really great way to be able to do that. That's absolutely perfect. I would say that's completely fine.
Do we know what the fee for the new plan reviews will be?
We look, we do. I wouldn't say I would hold out until it's done. The numbers have not been uploaded to the MBS yet. And I would just say to wait till it actually gets uploaded properly on MBS online.
Or how many TCO visits will be available to be allocated?
It's still 5.
Sorry, I don't know how to do the scan thingy. I'd love the template
Yep,
because,
no
oh,
worries,
yeah, yeah,
Sonia.
yeah,
I've
yeah.
got yours. I will
Yeah.
sort that out for you.
Can you co-bill 699 with 23?
No. So that's a health assessment and a general attendance item. So you shouldn't be co-billing the two of those together. The 699, if you have a look at a previous webinar that I've done, which is about the missed item numbers, the one that was last week or last few weeks, that's where I would recommend that you have a look.
There's just a comment there in the questions, in the chat box, but everyone can have a look at that. Can I use the nurse's time in the final time used for the GPMP for the self-assessment?
So in terms of GPMPs, they're not timed. So for the health assessment, yep, okay. Yeah, so this is absolutely fine. It's the timing of the health assessment, and at the bottom of it there, it says that you've got you've got 30 minutes with the nurse and 20 minutes with yourself. That's absolutely fine. A nurse is able to do it on the behalf of a GP. They need to be enrolled or registered to be able to do a health assessment.
And the next question there, AB, so GP and physio, who is the third?
I think that's in response to
Oh,
Andrea.
okay. Anyone got any other questions? We do have a little bit of time, so here we go. Here's another one. Who's going to
Yeah,
keep
so
track?
it's
Yep.
normally, yeah, so having a look at that. So they've asked who keeps track of the visits used, the patient, the practice, Medicare. How do we know how many allied health visits are used when patients return for reviews? So in terms of Medicare is a really good way of saying you've run out of your 5 visits because there's no rebate. But other than that, how you'll know that your allied health visits are used is likely going to be the patient is probably the best way for you to find out. You can also have a look on your health, like the health register, my health record, where you can see the billing that's happened for patients, and you'll be able to sort of see, oh, that's the podiatrist, that's podiatrist. You'll be able to see that if the patient gives you consent on the my health record, like Andrea is saying. But alternatively, hopefully you've got great providers who have sent you an email or sent you a letter saying, I've already seen someone once and I'm going to see them on the next few times. And if you haven't, have a look for some better providers.
Okay. There's no more questions at this stage. There is time. Um, it is being recorded as is the previous two. You can watch them on on the YouTube channel. I think Jade has put that in the chat for you. There is a couple more questions there. Ash,
Yeah, go for it.
we still we still phone, I presume that's Medicare, to check AHCP and eligibility.
Um, you can phone. I check Proda normally. I also have Cubico, which is another product not affiliated. And they also do a really good job of telling you who is able to have certain item numbers. How long do you make the appointments with the nurse and GP when you do a care plan, health assessment, etc. altogether? And do you do your care plan reviews on a normal GP appointment? Yes. So Liz, I'll do a combination of both. So in terms of how long I make the appointment with my nurse, and if they're doing a health assessment, I would say that I would give them anywhere between 30 minutes to an hour. If they're doing a care plan, it's normally 30 minutes at most. We do a lot of diabetics where I work, so they get a whole hour because they have a lot of lengthy education during that time. And do I do my care plan reviews on a normal GP appointment? Quite often, yes. So I'll take the opportunity that they've come in and see me and their care plan review is due at that time, and I will convert that appointment to also having a care plan review done. My processes are very quick. I have them done, the notes are already there, and it's not going to take an excessive amount of time. So for me, yes, I will often convert them to care plan reviews and then whatever they've come in for as well.
Excellent. Okay. Nothing, no more questions at the moment. Can I just remind you to complete the evaluation, the participant evaluation on that code? There's also an RSCGP feedback form. It's not compulsory, but if you wanted to complete it, you're quite welcome to. Thank you again, Ash, for another fantastic presentation. So good. We're so lucky to have you present to our members, and we look forward to your presentations again in 2025.
Definitely. Thank you, guys. Thank you very much. And any questions, please let me know.
Yeah. Ash is very welcome for anyone to email, and we can give you that email address if you need to. So I will end the webinar for all. Thank you, everyone, and we'll see you all in 2025. Bye.
Thanks. Bye.